So one of the things I think we can all absolutely agree with from David's presentation just then is we can actually see and hear how much impact therapeutic carbohydrate reduction and health coaching has made to his practice. You can just sort of hear and feel the energy, the joy, the satisfaction that he's got from his practice. Now, the other practitioners on the panel, Olivia, Lily, Marcus and Glenn, we've kind of heard from Glenn and Marcus to a degree with his paper, but would you all agree that what you are doing, the therapeutic carbohydrate reduction and health coaching within your practice, has it also increased your joy, satisfaction? Has it decreased your workload? So we're seeing similar things. So the first question I'd like the panel to answer, please, is everything's becoming better. So what can we do? What do you need to progress this further? From your experiences, how can you make this more? So starting from you, Glenn, this end. Pass the mic, just hold it possible.
Yeah, I think that's what I kind of thank you for, David, but also curse you for, because what you've highlighted is that we have a lot more work to do to even get close to where you are. I have so much admiration for the fact that as a full-time clinician, you have been able to create everything that you've done, including the data. You know, that is not an easy task. What we need to progress this is, I think we need a team of people, because I think you are an incredible individual, and I know for myself I don't have the capacity or the ability to do even a proportion of what you've done. So I think what we need is a team of people, you know, maybe probably 10 people to equate to one David, who you know, have skills in social media, who have the ability to run a charity, who have the ability to interact with media and with government. You know, I think we need to pool our collective resources with a proportion of the enthusiasm that you have in order to reproduce in New Zealand what you have done. And I believe that we absolutely can do that. So that's the challenge that we all face collectively.
Thank you. You were asking about what is meant for me as a clinician?
Yeah, from your experiences, how can you be doing more, progressing the work? What do you need to make it better?
We need health coaches in practices. We need to promote the whole area, publishing like we've been doing, talking about it, having happy meetings like we've got here, where we're all happy to be here and share a common purpose. Publishing. We need to remind conventional medicine just how it's not keeping up with the rest of the world. For example, Karen and I just got a letter accepted to the Journal of Primary Healthcare, letter to the editor, talking about the fact that low-carb carbohydrate reduction is not included in the New Zealand guidelines for diabetes management, type 2 management, which is just so behind the rest of the world. Spreading the word person by person, patient by patient, moving stealthily through society, sticking our necks out sometimes, just being enthusiastic and realising that what we're doing is actually enhancing our practice, both in terms of patients, in terms of job satisfaction, in terms of savings. It's just so positive, and that needs to be, I think, promoted. And we need to tell our colleagues about it and keep telling our colleagues about it, because one by one they may start to realise actually what we're doing here and start to move with us.
I've got another idea. I've shared this with Grant already. One of my early problems was loneliness and a feeling of vulnerability, because what I did was a bit unusual, so my colleagues didn't like it. And Jen taught me that you need to find your tribe, find like-minded people, and then you feel brave. So we set up a private Google group just for healthcare professionals where we could discuss clinical things in safety and in private. And that has been wonderful. I've now got 500 doctors on my Google group. I've got psychiatrists, I've got respiratory medicine, nephrologists, all in the UK. That makes me braver. It also means if I need hundreds of letters to go to the Minister of Health, I can achieve that in 3 days. Because I've got friends and I can say, here we go. The group is also used to disseminate interesting papers. And the important thing is not to deluge people with hundreds of stuff, but just this is an important paper. So I would suggest, respectfully, to Grant, that he set up a private Google group, and those of you who are healthcare professionals join his group and band together, become stronger and more dangerous and formidable.
I think for me there's two things. One is around the legislation or the guideline stuff, so particularly for type 2 diabetes, but also the nutrition guidelines. So I think that creates a barrier for rolling it out at a bigger level. And until we see that change, we're just going to have pockets of people that have it as an interest or a passion. But to be able to change the education system, we need that national guideline change first. And then once we have that, then it really is focusing on the education, and that's the education across the board. So that's the medical education, nursing education, dietitian education, health coaching, everyone across the board. And we're not here saying it's the only option, but it needs to be one of the options. And obviously we think it's the best option, but it is about what the patient really wants. And if things have worked for them, then that's really what they need to be doing. So we respect people's position, their preferences and what they like to eat, but there's a lot of flexibility in this whole foods, lower carbohydrate way of eating. But until we've got that higher up, and I know you can do a lot at the ground level, and I think it's that's come later for many countries, but many countries have already made that change, and I think New Zealand is definitely lagging in that respect.
Thanks, Lily. Hi, everybody. My name's Olivia Curry. I'm a GP from Christchurch, New Zealand. I think sometimes to do more is to do less, but then to do less, we do need to team up. So maybe there's a way that we can definitely work more collaboratively, because the list of GPs or other health professionals now do exist as a group. It was initially hosted by Precure, and then we kind of went independent because of admin issues. But maybe it is time to just team up again. And maybe I'll put a bit of paper out somewhere that if you want to sign up to that, that'd be really great. But anyway, what I totally agree with Lily as well, that maybe to do more is to make it easier for people to do good for themselves, because life is really, really stressful. And sometimes to be consistent in doing what you think is good, what you think that we need to do, is really, really hard. For example, if I go through a whole day without lunch, the first thing I crave is sugar. So how can we make that easy? And that might just be a ministerial thing, that might be an educational thing, there might even be a supermarket thing. So, yeah.
Could I have a supplementary?
Yeah,
Very policy is so great. Yeah. Another piece of advice, if I may, inexorable courtesy, politeness, inexorable courtesy and politeness wins medium and long term, because people have different views to me, but it doesn't mean I have to fight them, and there's never an excuse for being rude. And yet you can get very frustrated because you will meet prejudice and angry people. But if you're polite and courteous, you do win in the end.
I'm just going to ask the panel one more question, and I'm going to open the floor for questioning. So start thinking of your questions for the panel at this point. Panel, what is one thing that would have made your journey easier? So if you're thinking about advice as well, that you're giving to people going, this looks like something that I could do. What's the one thing you wish you'd known at the beginning of your journey that would have made your journey easier?
Thank you. That it is possible to remission chronic health conditions. I think that's the most helpful thing. Thankfully, I'm mid-career and times have evolved that we know the possibility now. So I'm really, really excited for medical students, trainees, new dietitians, new physios that are coming through, that we show them this possibility now. I mean, maybe like Dr. Unwin said, you don't want to be that generation where it is normal to prescribe 5 medications. So I just want to know, that's the key.
I think it would have been great to have more than an hour of nutrition training at med school. And I think that, we actually got taught the physiology of insulin resistance, hyperinsulinemia, how diabetes happens really well at med school, but what we didn't get taught was the practical application of that in terms of how that translates into food, which, isn't a big step from where our knowledge base was. So once I started learning about this, and I started learning in 2016, so it was kind of pre-cure. So I think now we're very fortunate that we have, an excellent training like pre-cure that anybody can access, remotely, online, but in a supportive way with, groups as well. So if that existed, it would have been awesome. But I think, going back to med school, it's that really practical application and how important that is. Like my mum was always big on healthy living and nutrition, and so it was one of my values, but not everybody kind of grows up that way. And I think that, the limited education we get on lifestyle and nutrition in all our health training is, it's abominable. So I think it needs to have a much higher emphasis in lifestyle change.
What an interesting question. I wish I had been taught about the true causes of chronic disease. I wish I'd done that earlier. I waited till I was 55. I'm coming to the end now. It must be, I'm 65. I wish I'd started younger. And I used to think I was a scientist. Doctors are not scientists. We never think about why is the person ill? Why? And of course, this is key to prevention. If you don't know why people have high blood pressure, how can you prevent it? Because mainly what medicine does is control with medication. And yet, for me, a brighter future is to do with prevention. I wish I'd known about the true causes of chronic disease much earlier.
My university was a progressive and new university, and I had no nutrition education whatsoever. I've learned it all in the last few years. For me, the most useful thing to have had when I first discovered low carb or carbohydrate reduction, etc., what it can do for people, would be to have a contact, someone local I could talk to and get advice from. I went to the internet and I did courses, and I met Lily, went to one of her evening sessions. But to have a ready contact would be so useful, to just get some basic advice. Because when you first start doing this, taking people off medication, especially diabetes medication, what do you take off first? And, what's the risk, etc. So advice, personal advice, is something I think would be most useful for lots of GPs. Lots of GPs probably are interested, but don't know where the next step comes from. So I think that for me would be the most useful.
I wish I had understood the health coach approach much earlier, and then I wouldn't have been trying to tell people what to do, and then I might have been more effective in the first 20 odd years of my career. So I wish I'd known the health coach approach, and I wish I'd had access to health coaches in my practice.
Thank you very much, guys. I mean, I think one of the really wonderful things coming out from what you've just said, especially around education, is we now have the resources available. We've got some fantastic resources available through the Public Health Coalition. David was saying, Precure. We've got, there's lots of places where we've got the training available, thanks to a lot of the international contacts that we have. So but mentoring, that's really, really important. And I think it would be fair to say that anybody really here on the panel would be open to being mentors to other people coming up and through. So, you've got to start, and then we grow it up by circles. But now, what questions? So we've got David and Louise, but what's going to happen is, for the purposes of the microphone, so when you ask the question, I'm going to repeat it back to make sure we pause it on the video. So starting with David.
Thank you, David. Thank you for your inspiration for us. David Beaumont, I'm an occupational physician and former GP. Glenn, what a fabulous parody of the bad consultation, good consultation. I heard you ask a question yesterday, which was, can we change doctors' minds? And sadly, we hear so many examples of bad consultation. I'm not sure what the answer to that question is. Can we change people's minds? Panel, can we change doctors' minds?
Okay, so the question coming through that I'm just going to summarise is, can we change doctors' minds? How do we move away from the traditional mindset of medicines first to lifestyle first? Who wants to start? Let's go.
I have no idea.
I have no idea either. I'm an eternal optimist, and I'm heartened by the fact a member of my primary health organisation is here today to listen, hopefully to continue to be nagged by me to make some changes that are going to benefit our patients and benefit the country.
Definitely, definitely. Let's remember that most people became doctors to make a difference. You and I, when we were young, we went to medical school, we were hoping to make a difference. So many doctors haven't found the way to do it. And when I showcase those before and afters, doctors are interested and think maybe it's possible. Not for all doctors, but some doctors definitely are open to the idea of hope, and they're open to the idea that they'd like to be better. And if we can ignite the idea that, wouldn't it be, what would it be like to enjoy practice? What would it be like to see heroes instead of heart sinks?
Absolutely. So I've got two experiences of this as clinical director at Turiki Healthcare, which is a large clinic in Mangere and Panmure. So we have 13,000 patients. We have almost 20 GPs working part-time in the clinic, and we've been doing low carb as a clinic since 2017. So the way that we achieved that was that it started with a patient, and we all saw his results, and we talked about his results, and we puzzled over his results. And then I started looking at the evidence and realised there was a whole wealth of research in this area. And so then I committed. We just had a clinic meeting and said, hey, look, this is the physiology, this is the evidence, it makes sense. Everybody said, yes, it makes sense. And we started. The challenge is the ongoing education. So we have to recognise that every person that comes into our clinic, every nurse, every health coach, every healthcare assistant that comes into the clinic has been taught by other people. And so, continual re-education needs to happen, and it's a long-term commitment. But having health coaches who, that's their bread and butter day in and day out, carrying the torch for that makes it much easier as a practice to make the change. And so really, as the GP, our role is really looking at the clinical safety to ensure that we are prescribing safely, de-prescribing before people start, so that they can actually do it without the risks that comes with, being on those medications. So that's, we've done that since 2017. In my new clinic, I've moved to Dunedin, to Te Kaika. I did the same thing. So, one of my first clinical meetings was about low carbohydrate. I got one of my low carb mates to come along, and we co-presented a 1-hour session on it. And for the GPs in the room, it was a no-brainer. It just took that time and clinician to actually have the conversation, because once you actually explain it, everyone was like, well, of course, and why not?
It's really encouraging to hear. In Canterbury, I think we're still working in a little bit of a silo. There's at least a few GPs here from Christchurch doing things quietly, but I think, I think it's probably reframing as well, and encouragement that it is safe to do so. And once you see your first patient remission to diabetes or whatever, can be, you've got patients coming in to say, I don't want to lose any more weight. It's great. And then before you know it, you've got patients coming off SSRIs for depression. It's great. And then before you know it, you've got patients coming off WINS benefit. You don't know what to do. I didn't know what to do with that. So I had to tell them the workforce is quite different now. Maybe can you go back on 10 hours a week? Maybe not 40 hours a week to start. So something like that, but that gives you the dopamine hit. So I think just continue doing what you're doing. And again, it's always a negotiation with your patients, and then find your tribe.
Thank you very much. So I've got a question that's come in from online, so we're just going to address that one. I know I'm extremely opinionated about this, but the question has come through as to whether you test for insulin resistance in your practice, and if so, what and how?
The blood test is very expensive, but the tool to measure insulin resistance is very cheap, and that's the measuring tape.
Yeah, so I work in populations where if it's not funded, it's not happening most of the time. And so we really are relying on those markers that David's already talked about that show that the person is insulin resistant. So that's the raised triglycerides, the low HDL, the HbA1c coming up later. That's one of the end things. The GGT, that's our little kind of, oh no, things are starting to happen. But, you can look at a patient usually and know that it started. It's definitely, I don't think maybe Glenn does, but yeah, I don't do any insulin testing or anything like that, but I don't need to.
I agree completely with Lily.
Ditto that.
I can provide a different perspective. I do measure fasting insulins, I measure fasting C-peptides. I find it useful, but I'm not looking at that in isolation. I'm looking at it in a global sense. You don't have to do it, and I think it's funded.
We were having this argument last night.
I think apart from in our local area, which is an anomaly, I've found it's been funded in other areas. So have a go.
Okay, I'm going to add to that just because this is actually my research area. I think there's some awesome tools coming up and through, but especially what David was talking about with the use of the continuous glucose meters and making sure people stay in time and range, but also measuring beta-hydroxybutyrate in the blood is coming through as a really, really effective marker. Right, now I know there's a question. Louise, I know you had a question earlier.
Louise Schofield, Precure. One for Glenn. Can you tell us a little bit more about the charity that is already set up, Reversal, and how can we be involved? And is that the one that we should all get behind? Will we try and get behind one of the existing, or do we set up new?
Okay, so the question coming back through that I'm repeating back for the online people is a question from Louise Schofield, Precure, for Glenn Davies. Glenn already is involved with a charity, Reversal Diabetes. Reversal NZ Charitable Trust. Is this the charity we should be getting behind, or are there others that we should be exploring?
I'd be absolutely delighted if Reversal NZ Charitable Trust could be expanded to work in conjunction with every other organisation that can contribute. So
Can you
I
just
think
give us a 2-minute as to what your charitable trust is about?
so. We started at Reverse T2 Diabetes Topol, which was a free community meeting that ran every Wednesday night for the last 5 years. When I look around the room, I think about 50% of you have, not quite 50%, but many of you have presented at those meetings for us, which we're really grateful. At the moment, it's not the charitable trust aspect of it's not doing very much. So absolutely, yes, it could be expanded, and we would be so delighted if that was what happened. And also to steal all of your resources from public health.
We did start the conversation at dinner last night, didn't we, Dave? Yeah, Glenn. Davis. So I think it's a conversation that we can carry on. We talked about giving back to the community. When the little things that we started independently starts to make a bit of a profit, we give it back.
I am a diabetes consultant, and I've been working in diabetes for many, many years, and I've tried to get people to sort of buy into this low-carb business. And I think I'm going to talk about the elephant in the room, and is that, David, you are keto. You follow a keto diet, and all the people who support the low carb lifestyle, they all buy into low carb and do it themselves. And how do you convince people, the non-believers, to do it? Because it is quite difficult. I mean, Brussels sprouts with butter chicken is all very good and well, but you go, I mean, I work at North Shore Hospital, and trying to find a low-carb option at breakfast, lunch, or dinner, going to Hawaii on holiday, there is nothing low-carb.
Okay, so just so making sure I'm understanding the question correctly, it's one thing to be able to say, let's be reducing our carbohydrate intake, but in practice, this can be rather challenging. And I completely hear what you're saying, because when I was a patient in hospital a few years ago, I was thinking, oh my God, the breakfast. I was better off fasting. The food options often when we're asking about are challenging. So what quite is the question? Is it about how do we...
Does the health coach and the whole team have to be evangelical themselves in actually saying, yes, I'm low carb,
so
I do it?
So it's about the people who are doing this need to walk the talk.
Absolutely.
But
That's such a good question, because of course in our practice we've got nurses, doctors, a full team. What I would say, it helps to understand that so I'm working in a poor area north of Liverpool. It's the National Health Service, so I can't pick my patients. So they vary. The important thing to say, it's lower carb, because so many of those poorer people are having maybe 300, maybe 400 grams of carbohydrate per day. So for them to move from 400 to 200 is real progress. And so many of my patients start like that, with a relative lessening of the carbohydrate when they understand. So they may not actually be low carb in terms of less than 130 grams. Many of them are not. But even that relative improvement gets results. So it doesn't have to be a zealous sort of low carb keto. I avoid the keto word. I just used it, but I avoid it, because mainly what I'm doing is helping my patients go lower carb, and I'm helping them to eat more food, more protein is what I'm trying, more green veg. So simple messages like that. I often begin with them photographing everything they eat, so that I don't give advice before I've seen where they are. Otherwise it comes across as a bit judgmental. So great question, thank you. Sorry.
I'd just like to add that my philosophy is to make it as simple as possible and as doable as possible. So you're not having fancy meals, you're having simple meals. It might be an omelette, it might be bacon and eggs, it might be sausage and sauerkraut, you know. It's my favourite. But you want to make it doable, and I often encourage people to have their top 10 meals posted on the fridge. They know they're easy to do, quick to prepare, and cheap, usually. So it's about making it practical and having people reviewed regularly, so to make sure they're on track and that they got the advice they need and that they've got the support they need. So it's not difficult, not necessarily expensive, and definitely doable.
Thanks for the question. I think it's really good and probably very important. It is the everyday how-to, and you're quite right, I'm totally in agreement with everybody else. But this is where the health coach model really, really works, because people do generally walk the talk, don't they? And like 80% of the time at the minimum, I think. And then it's also, you know, reading food labels. I work with a health coach that would meet people at the supermarket, and they would spend time looking at snacks, 45 minutes looking at snacks. And reading food labels and seeing how to do that. We run a similar group in Christchurch. I've abandoned that now for 2 years. But we used to meet at New World Supermarket in Hallswell, Christchurch. And after 20 minutes after talking, we go to the sausage aisle to look at what fillers are in sausages. And people are so surprised that they're paying for wheat in sausages. But people didn't know that. So little things like that are really, really helpful.
Okay, we've got time for one last question.
Hi, my name's Alba. I'm a GP in the Waikato region and working with the residents there. My question to the panel is, what advice do you have for GPs or doctors who are new in the low carb and metabolic health space? I've just been working with Progressive for 1 year now and really excited, but I'm just wondering, for people that are wanting to incorporate this into their everyday practice, particularly since there's a lot of resistance from some of the other senior health clinicians.
Okay, I'm just going to rephrase the question slightly. So the questions come through is what advice that you can give people coming into the practice, but I'm going to modify it slightly to what advice can you give people who are really excited about incorporating low carb into their practice, but are meeting resistance from their colleagues? How do you start to overcome that resistance?
I don't know, my mother would say just do it. Hence I am the way I am. There's enough evidence now, and it's safe. I think we don't wake up in the morning to say, I'm going to kill a patient. We don't do that. And I think when we do something like this, it's definitely with good intention, right? And maybe, and sometimes it's whilst low carb, I think we're definitely going towards food now because we do that 3 times a day. But there are other ways to improve health as well, like sleep and improving movement, exercise, fresh air, reducing stress. Those are all very, very important too. I do respect my dietetics colleagues and my nutrition colleagues, and sometimes it is more important to outsource those kind of topics as well. But with regards to getting penalized from our colleagues professionally, I think that's old news now.
I don't really like resistance, but I think that sometimes you've just got to walk the talk and continue on, and when you have the outcomes, talk about them. So, celebrating the successes, sharing the stories as David does, reading the research, the meta-analyses. I spent a whole year doing that to feel confident about my decision to change my practice. And so that was at a time where, as I said, there wasn't pre-cure training. So I think, if you can make the time to do the formal training, that's going to be another little armour that you've got to be able to talk about it confidently. So I think, you've got to do it when you're ready and where you feel like you've got enough to show without getting argumentative about it.
When I began in practice, all of the partners hated what I did. Every doctor in that practice didn't like, and we had terrible arguments. What you actually need are some results. So look for the low-hanging fruit in the practice. So I know if you took pre-diabetes, in our practice, if somebody has pre-diabetes, there's a 93% chance that we'll get a normal blood sugar. And you'd learn on safe, easy cases. Another statistic, at our practice, if the patient will go low carb within 1 year of being diagnosed with diabetes, there's a 73% chance they'll get remission. And if it's a new case of diabetes, they're not on drugs, so there's nothing complicating it. So those are easy cases where you could learn and show your partners what you're doing, and also have a sort of humility about it, where you say, I'm just trying this, I'm excited, I'm going to give it a go, and I'll let you know how it goes. So put a wedge in the door, start with some easy cases, and then gradually, I was going to the doctor's coffee with the graphs, with the cases, and I intrigued them with that, and the idea that it wasn't, I was just having a go, let's just see. Thank you.
I agree with everything that's just been said. Thank you, Arla, for that question. If you're asking about where to go to get more help, there's some shameless self-promotion coming now. If you Google Low Carb Doctor New Zealand, you get my Facebook group, and I'll happily talk to you for hours and hours on end about how to do this and where to go, and where to find more information.